Okay, welcome back, everyone. That was an extremely stimulating first section, and we're going to move closer to America, both geographically as well as I think to some extent with the health system details. This is going to be a shorter session, so Gaurav Sankaran is going to talk about Canada. We're going to do 20 minutes for the talk, and then we're going to do 5 minutes for the Q&A. So Gautam, take it away.
Thank you, Ben. It's a pleasure to be here, and I found the first session really stimulating and look forward to more discussions with other people. So I'm going to talk about the Canadian healthcare system. Canada is, of course, the closest country to the US in many ways. It's close culturally, it's close geographically. Most of you, or many of you know me, but for those of you that didn't know me, you wouldn't even know I'm Canadian from my accent, unlike Carol's lovely British accent that identified her as such. But our history of health insurance in the United States has diverged from Canada. So in Canada, in 1966, it's almost like a regression discontinuity, which is the minority government, the Pearson government, which was a liberal administration, had a minority government, and they needed the support of the Labor, or New Democratic Party, to survive. And the NDP pushed them to pass what was called the Medical Care Act of 1966, which set out the Canadian Medicare system. And this was right around the time that the US passed the US Medicare Act, but the Canadian system was a universal coverage, not coverage just for the 65 and over. The Medicare Act, the Medical Care Act, led to the creation of a series of provincial and territorial health authorities. And since that time, the Canadian healthcare system has been largely single payer. Because of the closeness of Canada to the US, the Canadian system cannot be thought of as being in isolation. So there are many spillovers to the larger US market, such as with physician labor supply. They don't have to go overseas, as Carol said, they can drive 50 miles and be in the US typically. With drug prices, where Bernie Sanders has talked a lot and Trump has talked a lot about Canadian drug prices and imports and stuff. We all know from what Ben said that US health spending is high and US life expectancy is low. But it's interesting to see that these trends have really occurred during the time since Canada passed single payer. So if we look at, this is a graph of the US and Canadian health spending and life expectancy. If you follow the blue and red lines, as a percent of, as a dollars per capita, health spending in 1970 in Canada and the US was very, very similar. And by the time we get to 2019, the US is a good, 50% or 40% higher than Canada's, right? Just a huge discrepancy. And that the trends in life expectancy are going the other way, which is to say that if you look at the gaps of life expectancy early on, they're much smaller than the gaps now. And we all know from the work of Deaton, Case and Deaton and stuff, that the US life expectancy is going the wrong way, while the Canadian life expectancy continue to increase. So at least at the first order level, it looks like we could do better doing stuff as they do in Canada. I'm going to have a more complex view of this, and there's a lot of details, some of which support that and some of which might support other conclusions. So stay tuned for that. So how does the Canadian system work? So each of the 13 provinces or territories has its own system. The biggest are OHIP, the Ontario Health Insurance Plan, and RAMQ, the Régie de l'Assurance Maladie du Québec. And so they're all differently run systems for each province and territory. The Canada Health Act of 1984, passed then with Prime Minister Jacques Chrétien, codifies the requirements. And there's a bunch of requirements that say, such as there's no balance billing allowed. But it's maybe less single payer than people think. So services such as dental care, eye care, some drug coverage, and out-of-country care are typically not covered by the provincial health systems. And many people in Canada have employer-based private health insurance. There's a market for that, just like in the US. And that market will supplement Medicare and insures some of these things for typically wealthier Canadians. Physicians in Canada are not government employees typically, so they have private practices. They're going to bill the government typically on a fee-for-service basis. But there's lots of market mechanisms that seek to reduce costs. So one of those market mechanisms are salary caps. So in Quebec, RAMQ, the health authority will say that, we'll put salary caps on the total billing specialists can do. So they're just capped at a certain amount. Hospitals are private. So they're nominally private, but they receive their base funding from the government. And so they're effectively quasi-public. And so this isn't just a picture of one of a big urban hospital considered one of the best or the best hospital in Montreal, the Jewish General Hospital. And just you can see, like, there's the original wing of the Jewish General, which is to the right of my screen here. And the original wings were built well before the Canada Health Act and stuff, before single payer. And so they were built in the 30s, and it was completely privately funded. And then there are newer wings. And this is one of the nicest and richest hospitals in Canada. And I've had, with many elderly relatives in Montreal, I've been to these wings many times. And they're nice hospitals. They compare, this is a nice hospital that the facilities might compare to some of the really good US hospitals like California Pacific Medical Center or something. But these things were built not with public money so much as this infrastructure was probably built with private donations. But the operating budget for the Jewish General Hospital and other hospitals will come from the Quebec government. There's also like publicly funded clinics, and many may be locally run by like city health authorities or district health authorities in Quebec. So in Quebec, they're called CLSC, or Centre Local de Services Communautaires. So what's happened recently with the system? There's been many more private markets for select services, such as MRIs, and also physician salaries have increased a lot. And I'll get to this, to physician salaries and stuff in a bit. So it's probably useful to think about the Canadian system through the lens of current healthcare research. Okay, so if we just say, like, what are the big topics in healthcare research? Well, one of the big topics that we see, and much of the research here is American focused, as Ben said, but not all of it. So one of the big topics is like adverse selection and switching costs of insurance. And just to point to, a couple of papers on this, like Ben's work in the AER and Handel and Kolstad's work also in the AER, and Abelak and Gruber have some papers, and they basically talk about, how insurance design leads to adverse selection, how switching costs can lower that, et cetera. In Canada, there's no choice of insurance. So these issues are basically not existent. You're not switching health plans, and there's really no adverse selection. Okay, another big theme of research has been reclassification risk, and this is the risk, which is creates welfare losses of if you get sick and you pay more for insurance. And again, there's work again by Handel, together with Handel and Winston, and Geely, Handel and Winston. I've done work with Sebastian Fleitas and Tony Losasso on this. In this market, there's really no reclassification risk. You're paying your premiums, if you call them that, through taxes. So there are no premiums. It's really not an issue for the Canadian system. A third big topic of research has been the value of choice, of patient choice, on patient utility, and ultimately on equilibrium outcomes. And so I'll just point to a couple of papers there. Like there's been the work by Carroll, by Gaynor, Proper, and Zeiler, and Bloom, Gaynor, Proper, and Van Reenen on UK and how choice has improved patient utility and improved, patients are making good choices. There's been the work by Chandra, Finkelstein, Sakarni, and Syverson that's said, in fact, healthcare choice has led bad providers to leave the market and increase productivity, and good providers to come in the market. So in the Canadian system, it's hard to understand what choice is. And unlike UK or Taiwan, we don't know, and there's not a lot of studies, but choice in the Canadian healthcare system is hugely limited by non-market mechanisms. It's not like you have a choice of all providers. Yeah, you do if they would see you, but they're generally at capacity. You don't have a choice of all hospitals. You kind of do, but if they're at capacity, you really don't. Because of this, there's just shortages of primary care physicians, big waits at emergency departments, and shortages of specialists. And these are all very common in Canada. But there's very few formal studies of this, none that I could really find recently. Though, I've seen 20-year-old studies because there's just few formal metrics of how much those shortages are. Another topic that's been very important in the US context is, and European context, has been bargaining and market power. So I'll point to like my work with Naveau and Town, papers by Ho and Lee in the AER and Econometrica, and a paper by Pierre Dubois and Sather. I don't know if I'm getting that name pronounced right. That's on like pharmaceutical bargaining. Bargaining is still very important in the Canadian context. And physicians here, are bargaining, pharma are bargaining, hospitals are bargaining, but they're bargaining with a single payer, right? So that it changes the dynamic, but it doesn't eliminate bargaining, informal or formal bargaining as a way that which prices get set. The fifth thing I'd point to is there's been a lot of work and this is mostly in the US context, about how patient and the design of patient and provider incentives might add quality. So I'll point to like Stark and Town's work on how MAPD plans get you to take more drugs when that reduces hospitalizations. Work by Inev, Finkelstein, and Williams on mammographies and the design there, and work by Eliason, Hebsch, McDevitt, and Roberts on dialysis and the design there, and how clinics might exploit it. Work by Hackman on nursing homes, and Decarolis, Polyakova, and Ryan on Part D. Lots of papers, but just a few examples. I think that the bottom line in Canada is with single payers, there's actually very little scope for innovation, unlike the US. The government just doesn't have the flexibility to experiment with this. The last sort of stream of research has been physician production functions and learning. And there's work by Chan, Jensko, and Yu on radiologists. And I have work with Keith Joyner and Pierre-Thomas Léger on the Montreal health system. And I think that basic ideas like production functions for physicians are very similar, and learning processes are similar, because effectively training is very similar across the two countries. Okay, what does the Canadian system get right from this comparison? Well, there's essentially no adverse selection and reclassification risk. And people just don't worry about financial ruin from getting sick as much as in the US. So we all have seen like Neil Mahoney's studies that bankruptcy is, in fact, medical bankruptcies are the biggest cause of bankruptcies in the US. That's just not happening in Canada. The other thing the Canadian system gets right is that compliance costs for providers are much lower. So there's only one, payer to deal with, and almost no cost sharing. And physicians, because of this, spend about a quarter as much time interacting with payers as they do in the US context. The other thing that they get right is that it's kind of the low and moderate income Americans that may lack health insurance and may lack access to non-urgent healthcare. And Canadians of that sort of income level are definitely have better access to non-urgent healthcare, including preventive healthcare and so on. Also, public health and integrative care, it's just much better than the US. And if you look at it, the COVID-19 death rate in a country that's very broadly similar to the US, it's 38% of the US rate. And the US should just be embarrassed about that statistic because we're such similar countries in many ways. The other thing that's happened, is that there's actually more physicians per capita in Canada than in the US, and salaries are actually relatively similar. And this is the number of physicians per capita. And you can see that the Canadian numbers have actually grown, and they're higher than the US numbers. And the salaries are actually quite similar, and they've really gone up in Canada over time relative to the US. And that's where our sort of common labor markets play into this. And my question to Carol, you don't need to you don't need to have special training to work in the US if you're a Canadian doctor. One of my father's physicians simply at some point left, and like a specialist just left and started working in the US, commuting from his home in the south end of Montreal and commuting an extra half an hour. And that's not maybe uncommon. So Canada's raised salaries for physicians. Even family doctors are very similar, and specialists are about 80%. Some of the very high-end specialties are going to be paid a lot more in the US than Canada, but this is overall. Where could the Canadian system improve? Canada really lags in the adoption of high technology frontier services. There's just a lot less availability of technologies such as PET scans. Like if you have a case of acute cancer and stuff, you want to get a PET scan, and be really hard to get one in Canada relative to the US. Same for MRIs. There's private markets for MRIs now in Quebec because the government knows that there's shortages, but they're relatively expensive. There's also a lot less human capital. So for instance, like one back surgeon that I understood he said that he was the only surgeon doing minimally invasive back surgery in Canada. Well, I imagine that there's way more than 10 in the US, even though the US has 10 times the population. So there's just like these sort of very high-end surgeries and novel procedures. They're going to exist in Canada, but at a much lower level than the US. There's also lots of inefficiencies in allocation. So talking to experts on the Canadian healthcare system and experiencing this myself, there's a lot of, it's not money directly that affects who gets the best care. In the US, it's about insurance and money, but in Canada, it's about social capital. There's shortages. How do they get allocated? Things get allocated to people who are high status. They have friends who are specialists. They're in the same social networks. So let's not kid ourselves and think that allocation in Canada is exactly fair. It's just different than the US. The other thing to say about Canada is, and this is again from people who really know this system well, is that physicians have a lot of bargaining power. It doesn't, we know in the US that there's a lot of regulatory capture, like there's work by Gottlieb et al. That recently on this, but it's also true in Canada. And, so for people who think, oh, single payer means like it's utopia, we'll just lower salaries for physicians, that's not necessarily true. Single payer does not imply no regulatory capture, it by no means, and we can see this from Canada. Maybe in other continents, people are nicer, but in the North American context, there's definitely regulatory capture. So if you just compare the healthcare issues in Canada and the US, so the US has relatively poor public health, but lots of high-tech services. In Canada, public health is better, but there's low adoption of high-tech frontier services. The US has huge expenditures and no shortages for people with private insurance or Medicare in urban areas. Canada has moderate expenditures, but there's a lack of EDs, of specialists, and even primary care doctors. The US has a lack of care in rural areas. Canada, in some sense, can solve that problem. They just force doctors to practice in rural areas once they go to med school, but it creates shortages elsewhere, like in big cities. The US has high cost sharing and narrow networks that limits utility. Canada has no explicit cost sharing, but the allocation is opaque and there are long waits. In the US, providers may exploit incentives such as literatures on upcoding. In Canada, it's more difficult to exploit incentives because of, for instance, salary caps. The government can be more heavy-handed there. The US has more pharma bargaining power and more of ability for big pharma to advocate, for instance, with direct-to-consumer advertising that's not allowed in Canada. Canada has lower pharma prices, but it has much less pharma R&D per capita also. So the US is just a leader. And this is sort of what I understand to be the implicit agreement with the MMA is no bargaining, but research happens in the US. The US has lots of choices for potentially uninformed consumers that may create choice overload. And in Canada, there's very few choices and physicians have a much greater power over the decision-making. So they really are gonna decide what treatments happen because they have a lot of market power and there aren't many choices. So if we look at just in conclusions, what are some lessons, overall lessons for the US? Well, the Canadian system is much cheaper than the US system, and that's despite a relatively similar physician wage bill. So, similar quantities per capita and similar prices actually. But the big caution is it's very hard to allocate efficiently with single payer systems. So even though they have the same numbers of physicians in Canada, they're not providing, there are long waits and there are shortages of everything from EDs to specialists to primary care docs. The other thing that, we all know that Americans live less long than Canadians, but one thing that's surprising maybe is that, it's not surprising that the poorest Americans live less long than the poorest Canadians by a substantial margin. But what's perhaps surprising to people in this audience is that richer Americans live longer than richer Canadians. So if we look at this graph, then these are two graphs. There's no apples to apples comparison. So they're two graphs that get at the same thing. In this case, the US numbers are from Chetty and they're basically the same. The Canadian numbers and the US numbers are life expectancy at 40 years. The Canadian numbers are life expectancy at birth here, and here they're life expectancy at 50 years. And what you can see from that, this is by income quantile. This is quintiles and these are vintiles. And what you can see is that there's a crossing point. Low income Canadians live longer on average than low income Americans. The red line is above the blue line. But at some point, fairly low on the income distribution, low income Canadians or high income Canadians are going to live less long than high income Americans. Okay, so there's a gap in both things. And the point at which it crosses the income distribution is below the 50th percentile. So another way of saying that is that the median American lives longer than the median Canadian, even though average US life expectancy is lower than average Canadian life expectancy. And that's saying something that, people, we don't know why, and we can't attribute it to healthcare necessarily, but I could give you many anecdotes from Canada where if you're old, a lot of stuff is not going to happen for you that would happen in the US, and many of those things can be shown to improve life expectancy. Okay, so just to conclude, and then so part of that is that part of that difference may be that high-tech frontier medical services are much more scarce in Canada than the US. But one big thing about the US, and this is something that Sung-Mei brought up also, is that the US just may have too many markets and too many choices. ACA, small group, large employers, Medicaid, Medicare Advantage, veterans, traditional Medicare. People often have choices of many different markets in which to buy health insurance. This fragmentation is not necessarily good for the ability to make optimal choices, for selection issues, and for provider compliance costs. And that is a lesson from Canada that we could do better by reducing the numbers of markets. Okay, thank you very much. And I'd love to hear questions. Should I stop? I'll stop screen sharing, I guess.
Absolutely. So thank you so much, Gautam. As with the first two talks, that's extremely insightful, and I learned a lot. You have quite a few questions, and so I'll try my best to curate them effectively. And so I'll start. I think what I'll do is I'll kind of start with the questions which are a little more specific in terms of hitting one precise element, and then go to kind of one or two broader questions. And so a more specific question asked by Samantha Byrne is that she says that a really controversial topic in Canada is whether to allow patients to pay for quicker access to treatment covered under Medicare. Could you talk about the economics and welfare implications of this? And I think that one other interesting angle there is, when we look at, for example, the Chilean market and the Australian markets later, that kind of supplemental coverage is going to be really prominent in those markets. My sense is in Canada, it's not prominent, but there's policies to make it, proposals to make it more so.
Yeah, I mean, so that's, it's an excellent point. And we all know from the Arrow impossibility theorem that there's no social welfare maximizing outcome, right? So, and Sung-Mei brought this up also, like, what is the consensus in the US? Like, should the same healthcare be a right for all, or is healthcare just a private good? And I would say that I personally, I subscribe to the view that like basic healthcare should be available for all, but there should be a market to buy better healthcare. We should all have cars with airbags, but if some of us want to buy Volvos instead of Chevys, then we should be allowed to do that, right? That's my sort of what I would think about for healthcare. The Canadian system is making baby steps towards that. I mentioned like MRIs. And so, as I said, there are 13 systems in Canada, so it's hard to know for every system. But if you look at Quebec, for instance, like there's now a robust private market for MRIs. And so you can go to a hospital, but you might wait 4 months for a non-critical, non-life-threatening MRI, like if you have a back problem, or you can just go to a private clinic, you'll pay about 700 Canadian dollars, and you can get it done within a few days. Right. So I think that even though it's controversial, they are making baby steps towards those type of things. But I don't think there's a private market for PET scans, for instance. They're probably just too expensive. But for MRIs, there is. You're muted.
Thank you. That's really interesting. In the flip side of that, you could think, of course, of patients migrating, which is not that easy, but it's doable for care across the border. But the flip side of that is kind of a question that Carol asked, which is, how much is the lower human capital in Canada? How much is the fact that there may be lower human capital on the doctor side in Canada due to migration of those doctors to the US? I don't know if there's any studies on that, but I'll just ask the question and let you.
Yeah, I mean, Carol, it's an excellent question, and I don't know that. I mean, there's excellent med schools in Canada, and it's more that the lower human capital is not that there aren't great doctors; it's that there are fewer of them, right? And I think it is true that, like, you look at like half the graduates from McGill Medical School, and anecdotally, like from my class in my high school class, many of the doctors are practicing in the U.S. right? And so I'm sure that that is a real constraint on them for keeping physicians in Canada with low, especially like the really high-end specialties and stuff. But like I said, things are changing on that because they have increased the salaries for specialists a lot. I mean, if you looked at that gap, it's not worth moving countries for 15% of your income, but it would be for 50 maybe, right?
Yeah, no, that makes total sense. And kind of moving to a broader question, and we'll kind of wrap up with this question. And this is a question that I'm going to ask, and this is my question. And the reason I'm going to ask my own question is because I also had this question for the prior talks and didn't ask it for Carol and Sung Mai, which is, you brought up this kind of tension between government monopsony and innovation, and you brought this up, I think, a little more in your talk specifically, where you were talking about the bargaining power of the government. And there's a really, there's a lot of policy discussion around the fact that, well, the US, because they're paying such high prices, actually helps spur innovation and creates a positive externality for other countries. And so I was wondering if you could just kind of talk about that a little bit and how you view that in the context of the Canadian system. I guess a more specific question is, should Canada be paying higher prices to spur innovation if the US is doing that already?
Yeah, that's an excellent question also. My sort of, and I haven't studied this with numbers, but my sort of heuristic or observational stuff has been like, there used to be a lot of like drug development in the Montreal area, and it's a big center for biotech, and there still is, but it's been going down, and a lot of them have been moving to the US because the US is more the hub of biotech innovation and pharma innovation. So, but if you're a small country like Canada, how do you compete on that? Like, it's almost like you're sort of like the government, I feel like, made an implicit contract with the MMA in 2003 that they were going to let drug prices be high, and implicitly the pharma companies were going to continue to build their innovation capacity in the US. If the Canadian government said we're going to not tie our hands and not allow centralized bargaining for pharma prices, would pharma companies suddenly move to Canada? I wouldn't count on it, right? So you're sort of, there's a big sunk cost in this. Like most of the the drug innovation is centered in the US, and I think there's a reason for that. And I would want, if I were Canada and I wanted to do that, I would maybe think instead of like explicit subsidies for innovation and targets for number of employees, and also taking advantage of things like our crazy immigration system in the US to help companies move to Canada and stuff, right? So
yeah, and I guess in some sense, and we don't need to talk about this because I think this is a more in-depth question, but it also depends on what we mean by innovation. I was kind of referring to the drug innovation, which is broader innovation. And of course, there's also more local innovation, like the kind of management techniques, for example, that Carol has studied. So, yeah. And that may be something that's non-exportable or importable.
But maybe it should be exportable, right? And even some of the studies in the US, like for instance, one of the ones I mentioned on dialysis, those markets for dialysis are all single payer in the US, they're all Medicare. But some of the ways that they incentivize clinics and stuff, they could be exported to other countries. So I think that's really important. And let's not forget, like, the biggest payer for innovation in the US is the NIH, which pays $45 billion, most of it to universities like yours and mine, right? And that's part of why the US is at the forefront of innovation also. But
yeah, but not enough to us.
No, not enough.
Fantastic. Well, let's wrap up just in the interest of time. Thank you so much, Gautam. This is, again, super fascinating, and I've learned a lot. So it's 10:53. Let's modify and let's take a 12-minute break. So let's start at 11:05. And the next session is going to be on family health with Katrine and Maya. And so we're going to kind of look at a slightly different angle, but I think a really, really important aspect when thinking about different health system design. So we'll be back in 12 minutes.